Using bedside ultrasound, the urinary bladder is an easy-to-identify organ seen as an anechoic, rectangular-shaped structure just below the skin line in the midline of the pelvis. In this module, I will cover the physiology of the bladder, scanning techniques, abnormalities in the bladder wall, and bladder intraluminal pathology. I will also explain how to measure for post-void residual, diagnose intra and extra peritoneal bladder ruptures, assess for bladder jets, and finally, how to perform ultrasound-guided suprapubic catheterization. The urinary bladder is capable of tremendous expansion and contraction. Its musculature is known as the detrusor and is made up of smooth muscle fibers. It responds to the impulses of the autonomic nervous system and involuntarily contracts. The method in which urine is stored and expulsed involves a complex extrinsic neural regulation mechanism. The storage component relies upon the viscoelastic and myogenic or muscular properties of both the bladder and the urethra. The release component, on the other hand, is dependent on the voluntary neural mechanisms that involve the brain and the spinal cord. Both the myogenic and neurogenic dysregulation can result in bladder disorders related to certain metabolic conditions, neurologic diseases, trauma, and medications. Compliance of the bladder relies on the viscoelasticity of the bladder wall during the filling cycle. Impressively, this organ can stretch, allowing filling volumes of 500 milliliters or more. But it is the inhibition of the detrusor action that allows, through complex neural modulation, the bladder to fill. Now, micturition occurs through a combination of urethral sphincteric relaxation as well as contraction of the detrusor muscle. After voiding, there should be little or no urine remaining in the bladder. The remaining is termed the post-void residual. In order to decide which transducer to use, it's important to remember the relationship of frequency and resolution and penetration. As you increase the frequency of the transducer, you will have improved resolution at the expense of penetration. So since the bladder is a structure that's down low in the pelvis, we're going to need to penetrate the sound into the pelvis, and the best transducer to use from a transabdominal standpoint is this large footprint, low frequency transducer. Now if we didn't have that probe, but we had instead this small footprint phased array transducer that's usually used for the heart exam, we could use that as well. However, that larger footprint probe definitely gives us better resolution at that wide angle. Now there's two views of the bladder. There's the transverse view and the sagittal view. In the transverse view, you've got the indicator to the patient's right, whereas in the sagittal view, you've got the indicator to the patient's head. But note, in either view, you really need to fan the sound inferiorly in order to see all the way down below the pubic symphysis where the bladder lies. This is an example here of how the plane is tilted inferiorly down to where the pubic symphysis is, so we can see the bladder as a very inferior structure. Again, the indicator to the patient's right in the transverse view. And once we see the bladder, what we're going to do is we're going to fan superiorly and inferiorly with the transducer, fanning all the way through the bladder to visualize its entire contents. In this way, we can actually, in this particular video, we can actually visualize the fact that this patient has a relatively pronounced enlarged prostate here seen posterior to his bladder. This is the exact location that you would see the prostate. It's posterior to the bladder. It's in the same location that you would see a uterus in a female. Now, as we can see here, in this female with this very full bladder, we're looking posterior to the bladder. This is where the location is of the uterus. We can even make out a cystic structure on her left ovary here. But again, the uterus posterior to the full bladder in the transverse plane. Now, when we switch to the sagittal plane, we aim that indicator towards the patient's head, and we're going to be fanning side to side in this case in order to see the entire bladder contents. And this is an example here of a transverse view and then going into a sagittal view here of the male pelvis. Now we're in a sagittal view, the bladder appears a little bit more triangular shaped. In that transverse view, it appeared more rectangular shaped. Now, with the female pelvis in the sagittal view, we now have the organ stretching out in their long axis. So what we see here is the bladder as a triangular shaped structure because it's now sagittal. And towards the indicator side of the transducer, we make out the fundus of the uterus up here. And then down here is the cervix. And this is the endovaginal canal here, or seeing this white echogenic hyperechoic structure here. This line is the endovaginal stripe. And as I lie the overlay over it here, we can make out the actual schematic diagram with the labels. We see the vaginal stripe seen here, terminates at the cervix, and the uterus is stretching out here, posterior to the bladder. So this is the anterior cul-de-sac, the fundus of the uterus is here, and this is the posterior cul-de-sac back here. And when the bladder is empty, we see now the bladder here is empty in this view of the female pelvis in the sagittal plane. We make out when the bladder is empty, this uterus becomes very anteverted. Here's that vaginal stripe, cervix, very anteverted uterus. As that bladder fills up, it will eventually push the fundus of the uterus in this direction superiorly, making the uterus less anteverted with a much more prominent bladder. Now, it is important to understand a couple of artifacts related to bladder ultrasound. One artifact is the fact that the bladder is a low attenuating structure. In other words, when sound encounters the bladder, the echoes behind it are enhanced, and that's why there's such a hyperechoic area posterior to the bladder. Therefore, that's also why we use the bladder as a window to visualize the anatomy posterior to it, the anatomy of the pelvis contents, such as the uterus and the prostate in the male. And when you see a bladder here, it looks very anechoic. Here's this anechoic structure here, this bladder, devoid of echoes, and posterior to it, we see it was very hyperechoic until we came along and adjusted the far field gain. By turning down the far field gain behind the bladder, we can compensate for the fact that the bladder is a low attenuating structure. The other artifact that we see is reverberation. Reverberation appears as equidistant arcs that come down from the top of the transducer. And so you can see this sometimes with the bladder, equidistant arcs coming down from the anterior part of the bladder. That's what this area up here is. These are just reverberation. This is reverberation artifact seen as equidistant arcs that come down from the footprint of the probe. This is common to see this with bladder ultrasound. The bladder should have a smooth wall throughout its perimeter, so the idea is to look for any irregularities in the wall, such as a focal mass, or any areas of thickening either in a focal location or diffusely, and any outpouchings like a diverticulum. Now, with regards to bladder tumors to be concerned about, there are really two types. The first type is transitional cell carcinoma, and these are found in people who smoke cigarettes, who are textile workers, painters, hairdressers, and metal workers. The other type is squamous cell, and these are more aggressive. Persons with chronic bladder infections or who have chronic irritation from catheters and stones are at risk for squamous cell carcinoma. So whether you see a solid mass or simply focal wall thickening, you must assume that the sonographic appearance of any focal wall abnormality must be cancer and worked up as such until proven otherwise. Now, this is a 68-year-old female with a history of urgency who had a negative urinalysis. And we can see here along the posterior area of her bladder, there are multiple tumors seen, masses seen back here, which turned out to be bladder tumors. Here's another example. This is a 72-year-old gentleman who had urinary retention and who had this post-void residual ultrasound. If you look closely there, you can see that mass shown by the arrow within the lumen of his bladder. Another example here of a bladder tumor. Along this posterior wall, as we fan through it, connects right up here. This location where the arrow is. When it comes to cystitis, the most common finding is actually a normal bladder wall. However, with repeated or severe infection, the bladder wall itself becomes thickened with focal areas of calcification often seen. Other findings of cystitis include the findings of intraluminal echogenic debris, or a stone within the bladder, prostatic enlargement, a bladder diverticulum, and urinary retention with elevated post-void residuals. This is a 2-year-old female with frequent UTIs who complains of fever and dark urine. She presented to the emergency department. On this bladder ultrasound, you can see diffuse bladder wall thickening consistent with pediatric cystitis. A bladder diverticulum results from a focal weakening in the bladder wall and herniation of the bladder mucosa through the muscularis layer. This can be congenital or acquired through high-pressure voiding through a distal obstruction. Of note, these diverticuli do not have muscle fibers and therefore they have no detrusor ability. This example here is a 56-year-old male with chronic urinary tract infections. He presented with abdominal pain, fever, and vomiting. A bladder ultrasound was done which initially showed what appeared to be a large, abnormally shaped bladder. However, upon further scanning, this initial object turned out to be a large bladder diverticulum that was adjacent to and confluent with the urinary bladder, which itself had a very thickened wall. So you can see this is the actual urinary bladder seen along here that's empty. A little more gain was applied so we could see it easier. And as we fan through its structure, we can see that there's a connection or a confluency with this bladder diverticulum. We can see that connection there. So this whole structure out here is actually the bladder diverticulum, and there's some debris seen layering out in its inferior location. Other findings to keep an eye out for are the presence of echogenic material. Bladders should be anechoic and completely devoid of internal echoes. The presence of debris swirling around in the bladder may represent evidence of bladder infection. If calculi are too large to exit through the urethra, they may continue to enlarge and reside in the bladder, ultimately becoming quite symptomatic. This 77-year-old female from a nursing home came in with abdominal bloating. Plain films were taken with concern for constipation, and this mass was seen in her pelvis. The ultrasound on the left depicts the bladder stone with prominent shadowing. This is a 69-year-old, otherwise healthy female who had urinary urgency for 6 months. You can see within the lumen of the bladder there is an echogenic calculus, which represents a bladder stone. There's acoustical shadowing seen posteriorly from the stone. This is an 89-year-old female who came in from a nursing home with foul-smelling urine and fever. And when we looked into her bladder, we saw an echogenic structure within the bladder lumen that also exuded posterior shadowing. This 27-year-old male is status post rollover motor vehicle crash. He had no seatbelt and he was traveling at a high rate of speed. Dark blood was seen in the Foley catheter, and intermittently the catheter was obstructed. Ultrasound of the bladder demonstrates clotted blood surrounding the Foley balloon. The bladder was irrigated copiously until the catheter was draining better. This 50-year-old male presented with known left renal mass and hematuria. His urinalysis appeared dark red, and this was his bladder ultrasound. Notice the presence of isoechoic blood clots settling out in his posterior bladder. All this isoechoic material here is clot. And this is actually the amount of urine that was left in his bladder after he attempted to void. Now we're in the sagittal view. We can see the clot is definitely at the inferior and posterior aspect of his bladder. Acute or chronic urinary retention can present with suprapubic pain and decreased urine output. In thin patients, a mass is sometimes palpated in the lower abdomen pelvis region if the patient indeed has a full bladder. However, if a patient voids, there is often confusion of whether or not they completely emptied their bladder or whether the amount that was voided was only a fraction of what remains. In these cases, post-void residual using bedside ultrasound is indicated. This is an example of how to measure the post-void residual. You start by first placing the bladder in a transverse view. You're going to need to measure the width and the height of that bladder. Then, after saving those values in the ultrasound computer, you turn the indicator towards the patient's head and measure the length of the bladder in a sagittal plane. So this patient's volume came out to only 20.2 cubic centimeters. Here we are in the same patient after they attempt to void, and we measure the bladder again in a transverse plane. We measure the width, we measure the height, and then we turn the bladder into a sagittal view and we measure the length, and their post-void residual is still 12.2 cubic centimeters. This is an example of how it's done using one particular type of ultrasound machine. We first take the value D1, and we're going to make this be the height of the bladder. This is in the transverse plane, and we measure from the anterior wall down to the posterior wall. Then we take the width of the bladder. In this case, we're measuring from the right wall of the bladder across to the left wall of the bladder, and we save the value. Then we unfreeze the machine and aim the indicator towards the patient's head into a sagittal plane, and now we're going to measure the length of the bladder. And the location with which we see the longest possible length of the bladder, we're going to measure from the superior aspect of the bladder over to the inferior aspect of the bladder. That is the length of the bladder, and that will give us, in this case, 437.8 cubic centimeters of bladder volume. Severe blunt trauma can result in rupture of the bladder, and depending on the mechanism, these ruptures can either occur at the dome of the bladder or down towards the neck of the bladder. If the rupture occurs at the dome of the bladder, the urine typically floods the peritoneal cavity. The intraperitoneal urine outlines the loops of bowel which are seen peristalsing adjacent to the empty bladder. This is a 56-year-old male who fell 25 feet. In this case, the Foley catheter with the empty bladder is just seen on the edge of that image just momentarily. But we can see here now these loops of bowel floating in urine. Here's another loop of bowel here. This is intraperitoneal bladder rupture, and the catheter, the Foley catheter, is just seen off to the edge of the screen there in the empty bladder. This is a 21-year-old female who fell off the back of a motorcycle at a high rate of speed and presented with multiple injuries. Now, her pelvis was really unstable, and she had blood coming out of her Foley catheter. On this bladder ultrasound, it demonstrates perivesicular urine and isoechoic blood clot just adjacent to her uterus. So this is all adjacent to her uterus. Here's the uterus right here. It comes in and out of the view. And we can see all this blood. Here's the bladder with the Foley catheter in it. And there's blood and urine seen collecting adjacent to the empty bladder in that perivesicular space just below her pubic symphysis. This is a 52-year-old male who crashed his motorcycle on the freeway and had severe pelvic pain. He denied any abdominal pain and had a negative fast exam for intraperitoneal blood. He had the continuous need to void but was unable to empty his bladder from his perspective. This is an extravesicular isoechoic structure seen here. This represents a pelvic hematoma, and there's a little bit of urine seen just adjacent between it and the bladder. So here's the bladder, here's that urine collection, and here's that isoechoic blood. This patient had an extraperitoneal bladder rupture, and what happened is the broken ends of his pelvic bone tore the anterior wall of his bladder close to its neck, and he's therefore unable to void. Color Doppler can be used to evaluate for ureteric peristalsis by showing periodic jetting of urine flow into the urinary bladder lumen from the ureteric orifice. You count the number of jets on each side to determine the total jet frequency. So the total jet frequency is the total number of jets counted from each ureterovesical junction over a 4-minute period. The relative jet frequency is the number of bladder jets on the symptomatic side divided by the total jet frequency. If the relative jet frequency is less than 40%, it's considered an abnormal test, and a CT urogram should be considered for an obstructing ureteral calculi. This is an example of a bladder jet seen coming from the left orifice and then the right orifice. The orange color indicates the bladder jet. This is using power flow Doppler, and note the low pulse repetition frequency in the 600s. This maximizes our sensitivity of the Doppler to pick up the urine jet. In this example, we turn the probe sagittally in the female pelvis. We can see the uterus seen superior to the bladder, and during a jet, we can see the jet firing on that inferior wall of the bladder. Sometimes if you overgain the image, you can actually see the grayscale of the jet firing along in the posterior bladder wall. Periodically, we can see the ureter contract and the grayscale flow of the urine posteriorly through the bladder wall. Blood at the meatus of a trauma patient is an indication to perform a retrograde urethrogram. Should that retrograde urethrogram show indeed a urethral injury, then Foley catheterization is contraindicated and a suprapubic catheter is indicated. To perform this, you use a Seldinger technique that is followed by first identifying the bladder in a transverse plane. The introducer needle is advanced under the transducer. If the approach is to place the needle under the long axis of the transducer, then the needle must be under the exact center of the probe at all times, otherwise it will be out of the plane of the sound and will not be visualized. However, when using the short axis technique, you simply fan the transducer back towards the needle while advancing the needle tip to maintain the tip of the needle under the plane of the sound until the needle tip reaches the bladder. Once urine is retrieved, you set the probe aside and advance the guide wire through the introducer needle and proceed in the standard fashion. As this diagram suggests, you can fan the transducer back over the needle in order to see the various aspects of the needle. Keep in mind that on the ultrasound screen, whether you're looking at the needle tip or any part of the shaft of the needle, the echogenic appearance will look the same. Another question that comes up is how far back away from the transducer does the needle insert through the skin when we're performing the procedure? Well, that depends on how deep the bladder is. If this is the skin line and the distance between the skin line and the lumen of the bladder is X, well then the distance between the center of the transducer and where the needle pokes through the skin should also be X, as long as the ultrasound is placed at a 90-degree angle to the axis of the bladder and that the needle comes in at 45 degrees. Keep in mind, this is when we're doing this in the short axis, underneath the short axis of the probe and not the long axis of the probe. But whenever performing this, it's important not to get too mesmerized by the ultrasound monitor, but make sure you adhere to the standard 45-degree angle of the needle coming towards the ultrasound probe, and the probe must be at 90 degrees to the axis of the organ. This is the short axis technique. Notice that the needle tip is not seen in the bladder until it is already punctured through the wall and is in the lumen. We don't see the needle tip just yet. We're advancing the needle, and eventually, once the needle tip reaches the lumen of the bladder, then we should see it. We can see the needle tip now. Notice that we can look at these hash marks along the side of the image. Each hash mark corresponds to 1 centimeter. 1, 2, 3, 4. Roughly 4 centimeters down is where we saw the needle tip. Therefore, the probe was 4 centimeters away from where the needle entered the skin, so long as the needle went in at 45-degree angle. Again, this is the short axis technique. To confirm that the Foley is indeed in the lumen of the bladder, ultrasound can then be performed. Once the balloon is in the up position, we can see it against the anterior bladder wall. Now, this 66-year-old male had a Foley catheter placed several days ago and was sent home. He returned complaining of urinary retention, and this is his Foley catheter that is no longer putting out urine. Bladder ultrasound shows the catheter in the correct location and the balloon is inflated. However, of technical note, the depth is too deep and this depth should be decreased so as to not to waste all this screen real estate. In other words, we have the depth here at 22 centimeters and really the depth only needs to be about 8 or 10 centimeters. Now, after decreasing the depth to 10 centimeters, now the bladder takes up most of the screen. The patient, though, continues to complain of urinary retention, and the Foley is still not putting out urine. After multiple attempts to irrigate and finally to deflate the Foley balloon were unsuccessful, a 22-gauge needle is guided percutaneously under ultrasound to rupture the Foley balloon for successful Foley catheter removal. In conclusion, urosonography remains the initial imaging modality to assess bladder function by demonstrating adequate storage volumes and complete emptying. Voiding dysfunction is easily identified by measuring post-void residual volume. The bladder wall with close observation of any intra- and extraluminal abnormalities are detected using ultrasound. And finally, guidance of suprapubic bladder catheterization can be done under ultrasound visualization to improve patient safety.